You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 7th, 2023. This week, European Hypertension Guidelines, vitamin D, bempedoic acid, leadless pacing, and some critical appraisal techniques thrown in. Also, a mention of the Icarus analogy. First topic is new hypertension guidelines. The European Society of Hypertension released an expanded guidelines for the management of hypertension. Journalist Sue Hughes has outstanding coverage, as always. Sue's writing is just superb. Now, you all know how I feel about guidelines. That is, I think there are too many guidelines, and these recommendations are made too simplified in those crazy colored boxes. Well, the goal of the European experts was to simplify the message. I have to say some of this is good, some of this not so much. But before I tell you about any of the messages from this guideline, one thing that we should set out is that excluding malignant hypertension, blood pressure is not a disease. It is a marker, a surrogate marker. Much harm can come from too much focus on surrogate markers. Now, the European authors have kept the definitions of repeated office systolic blood pressures of greater than 140 systolic or greater than 90 diastolic as the cutoff. And I say, okay, fine, that's probably better than 130 over 80. They've also issued clear guidance on measurement. The use of automated cuff-based measurement is favored. They also focus more on whole blood pressures as well, and I can't stress enough this management issue. I say that if you're planning to make changes in blood pressure medicines, there ought to be accurate, reproducible measurements, and I strongly suspect this is not being done everywhere. They did mention some issues with targets, and again, not too much new here. The consensus document notes that despite the smaller incremental benefits, an effort should be made to try and reach 120 to 129 systolic, but only if treatment is well tolerated. And of course, that's to avoid the risk of treatment discontinuation because of adverse events. And if patients stop taking their blood pressure medicines, they don't even get any of these incremental benefits. And so when I think of blood pressure targets, in my highly comorbid patient population here in Kentucky, I think of Icarus, right? Who burned up because he flew too close to the sun. And that's the problem that I struggle with treating hypertension in patients with a lot of comorbidity, is that if you just go too low, you end up with harm rather than benefit. Now, the most controversial aspect of the guidance, and I want to spend a couple seconds on this, is that the authors have upgraded beta blocker therapies to first line. This is new and curious and pretty much free of strong evidence. Now, as I grow older, I become less and less enamored with the benefits of beta blocker. I'm currently working on a rebuttal to this whole issue of upgrading blood pressure in these European guidelines with a colleague, and we offer multiple reasons for being against this recommendation. First is that the most important complication from hypertension is stroke, and beta blockers have the least efficacy for prevention of stroke compared to the other blood pressure lowering medicines. The second issue is that the authors have decided to upgrade beta blockers basically on a pragmatic basis because beta blockers can be used for a bit of a twofer, meaning that since beta blockers can treat so many other conditions, you might be able to use this one drug to treat two conditions, say you're treating hypertension and some other issue. Now, the problem with that is that most beta blocker indications for these other conditions are dubious. Now, of course, we all agree that beta blockers reduce mortality and heart failure with reduced ejection fraction. But for most other problems that beta blockers are used in, there's much weaker evidence. For instance, we're now learning that the common use of beta blockers in HFpEF may have been unwise. Now, another common use of beta blockers is in post-MI patients, but the evidence for that was taken from the pre-reperfusion era. Many of you might not even have been born in that era. Ongoing trials of beta blockers post-MI in this era are probably going to show no benefit, and since post-MI patients are at significant risk of stroke, it might be wiser to use non-beta blocker blood pressure reducing medicines in these post-MI patients. In sum, this change in blood pressure guidance is based more on expert opinion than evidence, and I find that problematic. All right, next topic, vitamin D. Vitamin D supplementation again made news, and I was going to ignore it because vitamin D use has consistently failed to demonstrate any benefits, including cardiovascular benefits. But the publication of the large Australian D-Health trial provides some teaching points regarding critical appraisal, so let's all push that stone up the hill one more time. D-Health is another big cardiovascular outcomes trial in Australia, 21,000 older adults randomized to fairly high-dose vitamin D, 60,000 international units per month, or a placebo. The primary endpoint was a 3-component MACE, MI, stroke, coronary revascularizations, and the events were counted via linkage with administrative databases. Now, these were older adults, mean age 69. About 3/4 had vitamin D levels above 50 millimoles per liter. Self-reported cardiovascular disease was noted in about 1 in 5 patients. The results, okay, let's talk. This was a non-significant primary MACE endpoint. It was reduced by 9%, hazard ratio 0.91, but the confidence intervals went from 0.81 to 1.01. So the confidence interval exceeded 1, and that does not rule out a no effect. The authors in many of the media reports attempted to highlight some of the subgroups and some of the individual components of the MACE primary endpoint. I'm not even going to discuss these because the trial was powered for the 3-component MACE. Individual components of the endpoint and subgroups are going to be highly susceptible to noise, and I'll come back to that later in the podcast. I want to say comments. First, we should remember that trials are like medical tests, right? They update our priors. If a trial was that positive, that it answered a question so definitively, one trial, that you needn't consider any priors, then I would wonder why the trial was being done in the first place if we were that sure. Now, here it is super important to consider the mountains of prior data on vitamin D, right? For instance, there was the VITAL and VITA studies, both large RCTs, both non-significant for cardiovascular outcomes. Now, I know people will argue dosages of vitamin D might be different, but I would also point you to a meta-analysis published in JAMA Cardiology in 2009. I'll link to it. This included 83,000 patients in 21 trials. Guess what the hazard ratio was for vitamin D supplementation in cardiovascular outcomes? It was 1.00. Confidence intervals 0.93 to 1.08. My friends, that is about as sure as you can get for no effect. So, with that prior data, 83,000 patients, 21 trials, if you added D-Health trial to that meta-analysis, I'm about 99.9% certain it would not budge the summary hazard ratio. So the way I see it, you have about a pessimistic prior as you can possibly have. You'd estimate the odds of any effect of vitamin D as very, very low, and D-Health, with its high-dose supplement and its 21,000 older adults and its non-significant 9% reduction in non-fatal cardiovascular outcomes, your priors don't change. D-Health doesn't move the needle. I've said it before, and I'll say it again, the research enterprise should stop burning money studying vitamin D supplementation. We should just tell people that there is unlikely to be an effect. If they want to buy vitamin D and take it on their own, then fine, but we should not spend any limited time in our office visits on vitamin D. There are so many higher value targets that are worth our time. All right, third topic, bempedoic acid. This is a rough one. Gosh, I'm going to try and stay calm through this. The author of Clear Outcomes Trial have published a subgroup analysis of the main trial in JAMA. The results are touted as highly positive. Primary author Steve Nissen has expressed his enthusiasm for bempedoic acid in the media, but this study is very curious. The findings are nuanced, and even if you don't treat hyperlipidemia, there is a trove of things to talk about. This is, I think, the most important topic of today's podcast. Now, first, let's do some background. We should set out what I mean by a subgroup. Simply stated, a clinical trial produces an average effect for a treatment in the general population who are enrolled in that study. Now, in that general population, in the study, there are all sorts of patients, right? There are men and women, there are older age, younger age, there's diabetics, non-diabetics, there's patients enrolled in one geography versus another geography. There's all these different subgroups. A subgroup analysis seeks to determine whether it's something called HTE, or heterogeneous treatment effects, which is awful jargon, but it translates to the question of whether there are subgroups that may benefit more or less than the average effect seen in the clinical trial. Now, in a perfect world, which we don't live in, subgroup analyses would only be done for one thing, and that is to form hypotheses for future trials to assess. But instead, humans fire up their cause-seeking brain centers and too often find signal, cause, when there is likely noise in these subgroups. And here is why. The number of patients enrolled in a trial is estimated from the expected rate of events in that overall population. Trials are powered to sort signal from noise for the entire population of the trial. Often, trials are underpowered because event rates are overestimated, meaning that there's too few patients randomized to sort signal from noise. But when a trial is adequately powered, a subgroup represents a fraction of this overall population. Think of a slice of pie in a whole pie. So a subgroup is almost always going to be underpowered, meaning if there's a difference, you can't tell whether it's noise or signal. Now, I've probably told you the most famous story of Richard Peto and ISIS-2, but I think it bears repeating. Famously, ISIS-2 is the trial that established the benefit of aspirin in post-MI patients many, many years ago. When it was published, the Lancet editors wanted to know if there were any particular subgroups of patients that benefited more or less from aspirin in the general population. Senior author Richard Peto said, no, you can't do that. There will be too high a risk of noise in the smaller sample of the subgroup. Lancet said, okay, we aren't publishing the paper. So Dr. Peto offered a compromise. He said he'd do the subgroup analysis if you let me do one based on astrological sign. And of course, he had the birthdays of his patients. And sitting in Lancet to this day, go look it up, ISIS-2 is the observation that aspirin exerts a major effect on outcomes in every astrological sign except for Gemini and Libra. Now, this was the most brilliant demonstration of how subgroup analyses are susceptible to noise because, of course, aspirin effects do not turn on your birth month. All right, now to the specifics of bempedoic acid, which is a cholesterol-lowering drug that works slightly upstream from statins. And Clear Outcomes was a large RCT, enrolled 14,000 patients who had statin intolerance, and they either got bempedoic acid or placebo. The primary outcome was a 4-component MACE, CV death, MI, stroke, revascularization. And the main results were positive for bempedoic acid, hazard ratio 0.87, 13% reduction. The confidence intervals went from 0.79 to 0.96, so this was a positive trial. Now, of course, the absolute risk reduction was small at only 1.6%. CV death, stroke, and overall death were not different, so the positive results in CLEAR outcomes was driven by non-fatal outcomes. The results show, though, that truly statin-intolerant patients do have a cholesterol-lowering option that has a modest reduction of non-fatal outcomes, and that's kind of a good thing. Well, it turns out that CLEAR outcomes enrolled two types of patients. About 70% had established heart disease, so-called secondary prevention patients, and 30% had a high risk of heart disease but no established disease, so-called primary prevention. And in the supplement of the main trial in New England Journal, the authors do report that both groups had reductions in outcomes, but the degree of reduction was greater in a primary prevention group. It was 9% reduction in the secondary prevention arm, but 32% in the primary prevention arm, and that 32% reached statistical significance. Now, the manuscript published in JAMA recently reported one of these two groups. You will never guess which one got the nod in this industry-sponsored study. Yes, of course, JAMA published results of only the primary prevention arm, which represented only 30% of the total patients and about 1/7 the number of events in the trial. So the total number of patients in CLEAR was 14,000, and this analysis included only 4,200 of these patients. The one in which bempedoic acid was used in primary prevention, half got bempedoic acid, half on placebo, and bempedoic acid reduced LDL cholesterol by about 21%. That's the same as in the main trial. There were 111 primary endpoints in bempedoic acid versus 161 in the placebo arm. That's 5.3% versus 7.6%, an absolute risk reduction of 2.3%. The hazard ratio is 0.70, or about a 30% reduction. 95% confidence intervals range from 0.55 to 0.89. So in this small slice of the main trial, this was statistically significant, like the astrological sign was in ISIS 2. But the authors went further. They were not satisfied with slicing just this one subgroup of primary prevention patients. They decided to slice it up even more, and they reported in the abstract for all to see that bempedoic acid significantly reduced MI and CV death by 39% and even all-cause death by 27%. Again, I remind you that these are individual components of an already small slice of the main trial. Now, these results led to many news articles with headlines such as, quote, striking benefit of lipid lowering in primary prevention. PI Steve Nissen from the Cleveland Clinic was extremely excited. Quote, these results are frankly striking. Quote, these are really large reductions. These results are telling us that high-risk primary prevention patients, although their absolute event rate is lower than secondary prevention patients, can have very impressive relative risk reductions in major cardiovascular events with lipid-lowering therapy. He said these new results are, quote, wake-up call for the medical community that we need to pay more attention to high-risk primary prevention patients. Now, fortunately, and quite unusually, was a strong rebuttal in an editorial accompanying the subgroup manuscript by Dr. Dhruv Kazi from the Beth Israel Group in Boston. I would highly recommend reading this editorial. Kazi points out that many of the, quote, cautions, as he calls them, are A, the risk of detecting noise. No, he calls it a type 1 error or false positive. He noted that primary versus secondary prevention is one of 38 subgroups. So by chance alone, you will see positive subgroups. B, he noted, the survival Kaplan-Meier curves separate immediately. Now recall that overall death was reduced in the primary prevention arm, but when you look at the survival curves, bempedoic acid seems to reduce death right away. Of course, this has to be spurious because if cholesterol lowering conferred a survival advantage, it's hard to believe that a 21% reduction in LDL cholesterol would do that. It would take years to have an effect, not days. And C, another caution that Kazi mentioned is that if you believe bempedoic acid does indeed have this heterogeneous treatment effect, I don't believe it, then the risk of cardiovascular death and MI and survival would have to be higher in the secondary prevention arm, as there were no differences in the main trial. Now, my comments. I have to say, this story really depresses me. It induces cynicism, and I hate when that happens. It's totally inappropriate to focus so much on this one of 38 subgroups. I've learned very early on in my career that you cannot slice data. Now, not only did they slice to one of the 38 subgroups, they sliced further into individual components of the composite. And of course, you could excuse this if this were junior researchers who didn't know better. But the authors of Clear Outcomes clearly know it's a dubious analysis. The JAMA editors know that it's dubious. But there it is, published and promoted in the media. They all know better and did it anyways. Now, how are we supposed to judge their neutrality, the authors and editors alike, when it comes to evaluating science? I'm asking. They published only one of the parts of the subgroup, the positive one. They mentioned the possibility of spurious findings, but not publishing the countering negative results in the secondary arm is just terrible. Yes, it was published in the supplement of the main trial, but they did not expand on it in the JAMA publication. Now, besides the issue of slicing data, finding likely spurious findings, is the fact that this strains plausibility, right? Why would primary prevention patients garner a huge benefit and higher risk patients do not get benefit or even harm from the same 21% reduction in LDL cholesterol? I mean, you don't see this with statins. The reason, of course, is that it is noise. The early separation of the survival curves in the primary prevention cohort is near proof of spurious findings. Now, to sum this up, I get it. People often criticize me for being a cynic, a guy not in the ring, not doing trials. Dr. Califf once referred to us as the peanut gallery. Well, here's the problem. It's hard not to be cynical about the research profession when you see stuff like this in the highest level journals. So I'm happy for anyone to offer a best case scenario here. Convince me, help me not to be cynical about this. All right, final topic, leadless pacing. Now, FDA has given approval to the first dual chamber leadless pacemaker. That's right, don't glaze over that. That means one bullet-like device in the RV, which is not new, we've had that, and one bullet-like pacer in the RA, and they talk to each other via some Bluetooth-like mechanism. Technology is pretty amazing. We shouldn't just glaze over it. For instance, at the lake this weekend, I watched my 2-year-old grandson chat via FaceTime to his cousin across the country. Now, both did this without any awe of technology. It's normal for them. But I thought back to my childhood where we watched the Jetsons talk on these video calls, and I remember thinking that could never happen. Now it is normal. It's the same with leadless pacemakers in both chambers, and technology really is something. But now we should get sober about this, right? Now, the background here is that leadless pacing has been around for a few years, and it has a small niche where it's very nice. Say, really sick patients with high risk for infection, such as dialysis patients, or post-op tricuspid valve operations, often in IV drug-related endocarditis. But leadless pacemakers are limited by A, they pace the RV, and thus they put patients at risk for pacing-induced cardiomyopathy. Until recently, leadless pacemakers were VVI only, so there was no AV synchrony. Now, one company does sell a VDD brand of leadless pacing, but its AV synchrony is quite imperfect. Leadless pacing is also more expensive than normal pacing. Now, Abbott has come up with his dual-chamber system, 2 bullets in the heart. They published a regulatory study in New England Journal of Medicine, and note I called it a study, not a trial, because there was no comparator. 300 patients with dual-chamber indications, obviously not permanent AFib, and they reported a 98% successful procedure. But they had 35 device or procedure-related serious adverse events, so that's a 10% adverse event rate. The primary safety endpoint was met in 90% of patients, and they said that it met the safety performance goal of 78%. That, too, kind of makes me smile, because who says a pacing procedure with up to a 22% bad event rate is a performance goal? Seems kind of arbitrary. The efficacy here was decent, as were the pacing parameters. And 70% AV synchrony was seen in most patients. And again, I question that performance goal of only 70% AV synchrony. Why is it 70%? A normal dual chamber pacemaker should be close to 100% in patients who don't have AFib. Now, since we now have very capable dual chamber pacers, most of the time capable of pacing with a narrow QRS via conduction system pacing, we should delve into the complications in these 300 patients. There were 9 cases of atrial fibrillation, and this is likely due to the trauma to the atrium putting in the atrial system. 1 patient had a loss of communication between the 2 pacing devices in the atrium and ventricle. There were 6 dislodgements, which are serious. There were 2 pericardial effusions, which is actually quite low, surprisingly, and a smattering of other complications. So just some brief comments before I close. The first thing to say is that early technology is always going to iterate. The first generation of CRT devices were really hard to place. They had low battery life, and now CRT devices are much better. And look, his-bundle pacing has now evolved, iterated to conduction system pacing. So this is the first step. But I am not enthusiastic about this particular device because, first, most times I'm doing a leadless pacer. It is sort of just to get a patient with lots of illness over a tough period. And if I truly needed a dual chamber pacemaker, I would not want dysynchronous RV pacing. I would want to do conduction system pacing. And finally, I'm sure buried in the press release and or marketing materials was the 10% complication rate. That is a really high complication rate. Now, it will get better with experience for sure, but that is still quite high, and these were experienced operators who were doing a study, and you can expect complication rates probably to be higher when this thing is released into the real world. If I were in charge of the FDA, I would give only conditional approval. That is, I would require serious post-marketing studies. Maybe they did, but I did not see it. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating. Those 1 or 2 sentence reviews goes a long way for others to find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.